evening. I'm Dr. Virginia Kane, the 125th President of the National Medical Association. I'm also the Director and Chief Medical Officer for the Marion County Public Health Department in Indianapolis, Indiana, and an Associate Professor of Medicine in the Division of Infectious Diseases at Indiana University School of Medicine. We're here to discuss a critical issue currently shaping the future of Medicaid funding, including the Federal Medical Assistance Percentage, or FMAP. As many of you know, FMAP is the United States government's formula for determining how much federal funding each state receives to support its Medicaid program. It plays a significant role in how states manage their healthcare systems. Today, we'll dive into the latest and potential changes to Medicaid, including the proposed reductions to Medicaid expansion funding and the elimination of the FMAP minimums. So, more than 72 million Americans rely on Medicaid, and low income families, children, those with disabilities, and those in rural populations are a few of the areas that would be most affected by any changes. Now, these changes could have far reaching consequences for states, healthcare providers, and most importantly, our Medicaid beneficiaries. And since the implications of these shifts could affect millions of Americans who rely on Medicaid for their health care, we're here to explore what the changes could mean at both the federal and state levels. So we'll also examine how these proposals could impact state budgets, the quality of care, and the broader healthcare landscape. So this is an important and timely conversation, and we hope to leave you with a clearer understanding of the issues at hand and how they will affect the future of Medicaid. And I'd like to take this opportunity to talk to you about one of our important panelists having this discussion is our NMA President-elect, Dr. Roger Mitchell, who is the president of Howard Hospital. Dr. Mitchell.
Thank you, Dr. Kane. And Dr. Kane, again, your leadership on these types of issues is so critically important. And your lens in providing opportunities for public health access to our nation's most vulnerable is why we follow your lead. My name is Dr. Roger Mitchell Jr. I am the president-elect of the National Medical Association and president of Howard University Hospital. And I'm excited to be here because we are in for a very informed conversation. I'll be the moderator of what we're calling a fireside chat to really explore these issues that Dr. Kane has framed. To keep in mind that the National Medical Association is the oldest and largest group of Black physicians in this country, started in 1895. And our origin and our current space is to bring this type of information to our members and to our community. So why further delay? We are going to have a deep conversation with Dr. Bruce Siegel. Dr. Bruce Siegel is the president and CEO of America's Essential Hospitals. Since joining America Essential Hospitals in 2010, Dr. Siegel has used his healthcare management policy and public health experience to advance the association's advocacy, leadership development, and health equity work. America's Essential Hospitals has grown dramatically under his stewardship, becoming a stronger voice for the hospitals caring for low-income and other marginalized patients. He served previously as director of the Center for Health Care Quality at the George Washington University. and as president and CEO of two member systems, the New York City Health and Hospitals Corporation and Tampa General Healthcare. He also served as New Jersey's Commissioner of Health. I'm happy to have him both as a friend, a colleague, and an expert to really be able to drive home the message surrounding how Medicaid can be affected by policy that we're facing today. For full disclosure, Howard University Hospital is also a member of America's essential hospitals. Dr. Siegel, it's great to have you.
Great. And I just need to get on the video here. You could just turn me on. Great, thank you. Thank you, Dr. Mitchell. Appreciate your leadership of the NMA and also of Howard University Hospital. And also thank you, Dr. Kane at Marion County, which is also a member of our association. And both the organizations are critical parts of the safety net. I am thrilled, may I say an exaggeration in some ways given the subject, but it is very timely to have this conversation here. Just as by brief background, Medicaid and the CHIP program, which is also part of it in a way, cover close to 80 million Americans. That's almost a quarter of our nation depends on Medicaid. And of those 80 million, almost half are children. So Medicaid has a huge impact on the earliest formative times of life. Medicaid also provides coverage for people with disabilities, with both physical, intellectual, and others, people with complex medical needs. And it pays close to 40% of the long-term care bill in our nation. So it is a critical part of the safety net, aimed squarely at low-income people of all races and ethnicities. And we can talk more about that. With the Affordable Care Act, Medicaid was dramatically expanded. And that expansion continued through the pandemic as more people required its services. That expansion, this program, has led to a decrease in disparities in health insurance coverage, disparities in access. It has also helped people, not just in our urban areas, perhaps even more so in our rural communities. And we've also seen medical debt and financial insecurity drop as a result of people getting on Medicaid. Now, the crisis we face in the next coming weeks is that with a new administration, which is looking for things to cut to fund the continuation of tax cuts that were first passed in 2017, there is movement in Congress to cut close to $900 billion from the Medicaid program over 10 years. That will have a huge impact on the populations that we talked about. So I appreciate this opportunity to have a conversation and some education about what this program does and why we need to speak up loudly for it. Thank you.
So thank you, Dr. Siegel. Let's jump right in. I know that we have some questions that were sent to you and that we'll get to, that was curated from our Health Policy Committee. As president-elect, I serve as the chair of the Health Policy Committee for the National Medical Association. I really want to kind of talk through, there are approximately 7 or 8 provisions within the proposed cuts. And I would like, if we could, to potentially take them one by one, if possible, to get an idea and a flavor for what it means. The first thing is the per capita caps. I understand that Medicaid, this FMAP, right, which is what we know as federal medical assistance percentage, is a percentage that the federal government provides the states towards its Medicaid subsidy of healthcare delivery for those that qualify, right?
Yes.
And so when we talk about per capita caps, can you educate us as to what that means and how that may factor into this
Right.
FMAP?
So the two are linked. So if you look at the FMAP, the federal medical assistance percentage, it varies by state. Wealthier states, the federal government pays for half the Medicaid program. In poorer states like Mississippi, it's as high as 77% is picked up by the federal government. And one of the proposals that is being discussed in Congress, and we'll see a potentially action on in March, is to start reducing that percentage. And there's various ways to do that. One would be to cut it across the board. Another would be to cut it just for those states at 50%, and that's a way of targeting certain blue states, if I could call them that, wealthier states like Maryland and New York and California and places like that. And then there's also an idea, when the Affordable Care Act was passed, the federal government said, we'll pick up 90% of the cost for those people who are now getting on Medicaid for the first time. And so as a way, frankly, to undermine the Affordable Care Act, some people have proposed, well, let's cut that 90%. Because in some states, like Arizona, if that percentage goes below 80%, the state withdraws its Medicaid expansion, called a trigger law. So it would be a way to roll back coverage for millions of people by cutting that percentage. Now, that percentage also pays for the care of every individual. And under per capita caps, what it's saying is, well, we're going to put a limit on how much we let you spend on each person. And that limits how much we have to give the state, essentially through the FMAP mechanism. But what it really is saying is we're going to shift the risk to the states. We're going to kind of cap how much we give you. And if your patients turn out to be sicker than we thought or require more care in a given year, those sorts of issues, sorry, you're out of luck. And all of these things will, really shift the cost to the states who can't afford it, and force the states to either raise taxes to continue providing the services, or honestly just to cut back in the ways that I'm sure we'll talk about more.
So that's a good, so per capita, it is a way for part of us to understand the richer or poorer states. Um, there's also a provision in the cuts that is looking at a work provision. Talk to us about the work provision and what that is and what the policymakers mean by that.
Yeah, so these work requirements were an idea that were actually go back to the first Trump administration, and they were tried in Arkansas. And basically what they said was, well, we think that people who get Medicaid or frankly who get any kind of social service or safety net program should be forced to work. And so you make people go through lots of eligibility determinations to find out if they're working, are they looking for work, should they be working, or are they busy caring for somebody in their family, etc. And what you find is that most people on Medicaid are in families with working people. So when you put these requirements on it, you create an artificial barrier, which says, here, jump through all these hoops, even though you probably shouldn't be working anyway, probably can't work anyway because of your health, or because you're caring for children, you can't get childcare, etc. But it's a way of keeping people off the program. Now, these were essentially deemed illegal by the courts some years ago. Arkansas did try it initially. Tens of thousands of people lost coverage as a result. There is a small work requirement program with Medicaid going on today in Georgia. 240,000 people were supposed to get on Medicaid in Georgia, but they put work requirements on it. The number dropped to 5,000. And that program today is spending 2/3 of its money on administrative costs, 1/3 on healthcare. Work requirements don't work, to be honest.
Especially if you're trying to save money. I think
Yes.
that last statement, if we're trying to save dollars, to create an administrative burden to make sure that people are working to get on the program that costs more than actually providing health care to all the people that need it, then it may not be meeting the goal that you're trying to meet if you're trying to give adequate and equitable health care for a lower cost. If that's your goal, you might not be able to meet it with work requirements.
No, and I would say you won't, because not only are you making people go through these obstacles, you're often making them go through every year. So you lose any kind of, continuity of care, which, as physicians, we all appreciate. So people have coverage and then whoops, they're off for 6 months, but they couldn't find, get the paperwork in, or somebody lost it, or, somebody decided we don't think you met the requirements, et cetera. It's just a lot of hoops. Now, some people like it. It'll save the federal government a lot of money. And it'll do that primarily by removing coverage from people, which is, I don't think is where we want to be. And I don't think that's something good for this nation or our economy in the long run.
We're going to talk about the effects. I have a couple more questions about kind of the cuts to really set a framework for our members and those that are watching online, and quite frankly, those that will be watching this in the future for many months to come as we grapple with this question and help our policymakers grapple with this question. We hope that we can use some of this content that we're generating here to educate policymakers, to help them understand the scope of the problem and why, no matter if you're Republican or Democrat, why these are just not the right way to go about saving dollars, is to cut really essential safety net healthcare delivery in this country. We talked about a ceiling of 90%, and we talked about 50%. 50%, you said that a couple times. That has been termed like an FMAP floor. One of the considerations in the resolutions that is being generated within this reconciliation bill is to decreasing the floor from 50 something lower than 50%. Can you talk a little bit about what that means?
Yeah, so essentially, those wealthier states who get that lower match, 50%, would be lowered further. And, I would never want to accuse anybody of politics, but those wealthier states tend to be states that, of a political blue tint rather than red tint. They're mostly Democratic states. Probably the only one that's not completely Democratic is Virginia, that is 50% floor. That is essentially a cut to the states. Let's be clear about that. It is saying to the state, we are just going to reduce how much we give you to pay for the care of these people. And a cut like from 50 to 40%, you're talking about tens of billions of dollars on an annual basis. These are enormous numbers. It would force these states to either raise that revenue in some other fashion. I'm not sure they could, or it will force them to say, we've got to cut back in some way. We got to cut our payments to providers. We've got to, pull back from supporting long-term care and support services. Those sorts of things will be on the table. And I think at the end of the day, what you'll see there, and this is what should really just concern us, is millions of people who had coverage, including the most vulnerable among us, losing that coverage because the resources just simply aren't there. And, I hate to put too fine a point on it, but this is in order to enact tax cuts, which will mostly accrue to people who are certainly not on Medicaid.
Yeah.
We have to decide, is that a trade-off we want to make? And I would say no.
Yeah. Last one of the parameters. This is not the last parameter, but I want to get to some of our questions here, and then there's several questions that I know that we're going to generate. If you are watching this and you're watching this live, you can start posting your questions in the Q&A area. We'll get to them, as many of them as we can. If you're watching on Facebook Live, feel free to put your questions in the chat. If we don't get to them live here, then we'll have a staff member make sure that we curate those questions and make those questions available live on our website, and we'll make our website available in the chat. So, Dr. Siegel, I live in DC. Live in the District of Columbia. I'm a proud DC resident. Would hope one day we'll be the 51st state. And there are no states that are in the provision of cuts, except for one.
Mhm.
There is an actual provision within this conversation of resolution for a rolling back of a DC FMAP provision that has legislated DC FMAP at 70% standard versus 50%.
Right.
Can you talk a little bit about why DC would be singled out in the midst of all these cuts that may go to Medicaid? Why DC to be signaled out?
Yeah, well, there's some people who don't like DC. I think that I don't think it's a secret that House Republicans for years have tried to exercise lots of oversight over DC and control in many ways. We've seen that, and that's not my opinion. That's I think a part of the historical record. I think DC is a very instructive example. So DC has a higher FMAP, but it has it for a reason. It gets more federal money than other places because DC can't raise enough revenue because so much of the land is taken up by the federal government, which it can't tax. And when DC was gaining more autonomy, it also assumed huge pension liabilities for workers. So this was a conscious decision by Congress to give DC a higher FMAP than otherwise. The proposal, which would micro-target DC, for reasons that we can all speculate about, that 20% cut in FMAP just for the District of Columbia would take away $800 million a year in Medicaid funding to the district. $8 billion over 10 years. You're talking about over $1,000 for every man, woman, and child who lives in DC would be extracted from DC. These are punishing cuts. And DC has done great work in terms of building a safety net. DC, I think, should be proud of that, frankly, in terms of the coverage expansion that's done, in terms of its health centers, its hospitals, its services. All that would be more than jeopardy. It would be rolled back as a result of this change in DC.
So let's stay there on the effects. Now that we kind of framed several of the major elements of the cuts that are being proposed, can you talk about how this would exacerbate existing disparities with this type of revision of the program?
Sure. So remember that Medicaid essentially charges no premiums. It has essentially no copays. It also, many people don't know they're on Medicaid. They know they're in some HMO plan. They don't realize it's Medicaid actually, but it's being done through a managed care plan. When people are on Medicaid, they're getting access to services for usually $0 that they couldn't afford or have. You're talking about vaccinations for children and well child care, talking about prenatal care. 40% of the births in America are paid for by Medicaid. And we know the huge disparities we see in those areas. We see what's happening with outbreaks of vaccine preventable illness. And I won't get into the whole vaccine thing, but I think we agree that vaccines have a great role here. We see the disparities in maternal health, including and especially for Black women and maternal mortality. Medicaid combats those things. It combats the hopelessness of someone maybe low income, have intellectual disabilities, and now has community support paid for by Medicaid that allows them to have a job and a dignity that comes with that. Those are the things that we are looking at taking away when we slash Medicaid as is being discussed. And I hope that we have the steel as well as the savvy to stop these things, because this will be a political process. I'll talk more about that, but it's one that we have to engage in, which we are engaging in, to ensure that these things don't happen. So much promise will be lost as a result of these punishing reductions that are being talked about.
You briefly in your open remarks and said it again a moment ago, children. children being one of the largest beneficiaries of the program. Talk a little bit more. I mean, you talked about maternal health, but talk a little bit more about how our children would be affected if these cuts are put in place.
Well, if children don't have coverage, and they are, like I said, virtually half of the whole Medicaid program, we're not going to see the early preventive services that Medicaid has been famous for since the outset. Diagnostic testing, well child care, vaccination, routine pediatric visits. Often these are school-based services. These are things that we know have huge economic and healthcare benefits for a person's lifetime if they have that start early on, before the age of 5. And if they have, issues and challenges, and disabilities, and need enabling services, Medicaid is there to provide that. So we risk taking that all away. And I think that has grave implications for us, both in terms of the health of our communities, but also the vibrancy of our communities. I mean, there's a reason why Medicaid is so popular, and that is something we need to understand. 77% of Americans like Medicaid. They have favorable opinion of it. That includes a majority of Republicans. Most Americans have either been on Medicaid or have had a family member, often a child, who's been on Medicaid, and that has shaped their perceptions, which are very positive. Recently, I'm not usually in the habit of quoting this gentleman, but Steve Bannon last Thursday on his podcast said, Medicaid, you got to be careful because a lot of MAGAs are on Medicaid. I'm telling you, if you don't think so, you are dead wrong. So he's telling House Republicans you shouldn't cut Medicaid. That's coming from Steve Bannon. And there are some congressmen on the Republican side who are saying that as well. So we need to empower some of these people, activate them, get to them. Some key people on key committees like Energy and Commerce in the House in the weeks ahead, not 2 months from now, in the weeks ahead, because it's urgent. This is the time.
Yeah, I like the fact that you're talking about the diversity of use, right? Some of these terms, when you say Medicaid, some that don't know think of, a black face or, an individual that is minoritized and marginalized from the standpoint of race. Um, Talk a little bit about the rural effects and maybe how rural America may be impacted by Medicaid cuts.
So, you bring up a great point, which is critical. We have this image, or some have this image of who a Medicaid beneficiary is. Well, let me tell you, the largest single group of Medicaid beneficiaries in America are white. They are 40% of the program. Second is Hispanics at 30%, African Americans at 19%. There are twice as many white people than black people on Medicaid. Rural access, important for all populations.
That's right.
Absolutely critical. There are so many counties in this country who are served by one critical access rural hospital, where if you look at the patients there, because there's really no industry there anymore, there's no commercial insurance. Most of the people are on Medicaid or a significant portion, or on Medicare, or on both. They're dual eligibles, usually the poor elderly very often. These hospitals are in trouble. It has been a crisis for decades, where you have dozens of hospitals, especially across the South and the rural West, closing because of what's happened with their economies. I do not want to imagine the havoc that would be caused if these cuts take place. We will see hospitals closed. We will see many hospitals closed in our cities, but especially in these rural areas where these places are already on life support and are on the brink of extinction, frankly, in many places.
Yeah, and I think that our members and the listeners and audience for this conversation really have to understand that this is a truly American issue of ensuring that we have healthcare delivery to everyone that needs it, um, and making sure that it's not just the children, it's not just the poor, but talk a little bit about the dual eligible,
Yeah.
and maybe even define that. I'll leave it to you to define what we mean by the dual eligible, for this program.
Yes, it's a thing we don't probably talk enough about. So there are, millions of people in America, I think well over 13 million, who are dual eligibles. And what that means is they're eligible for both Medicare and Medicaid. And they fall into a couple of categories. They tend to be folks over 65 who are on Medicare, they're entitled to it, who have very low incomes. So they're poor folks over 65, often in rural areas. And for them, Medicaid does things like pay for their, premiums for Medicare, pay for their copays, which can be pretty stiff in Medicare. So it's sort of a wraparound to help low-income Medicare beneficiaries. Then you have people who are, considered officially disabled, who are eligible for Medicare, who may be less than 65. They're often pretty sick people. They need a lot of help, intellectual disabilities, physical, et cetera. They also are covered often by Medicare and Medicaid. And for them, what the program is doing is what we call long-term support services. That could be nursing homes. Even better, it could be community-based support. So they don't have to be in the institution. So they don't have to be in a residential seating. They can be out in the community. These people are high needs people. They need a system of care coordination. And, when I see dual eligibles, I think about really the most sensitive part of our population in terms of their need for healthcare and their need for the financial security that Medicaid can provide as part of that. That's a group that I think is going to be very, very much impacted. They're high cost. And, if somebody wants to save a lot of money on Medicaid, that's a group you cut back on. And that would be a shame.
Yeah.
Frankly and truly a shame.
Yeah, and risking lives, particularly, are those that are elderly and don't have access, because of finances. Man, we're really talking about life-threatening policy here.
Yes.
I'm going to pivot a moment and ask our president, Dr. Virginia Kane, and our immediate past president, Dr. Yolanda Lawson, to join us here in our virtual stage. I want to give them an opportunity to ask a couple of questions of you. We have about 10 minutes for our presidential panel, um, and give an opportunity for them to engage in some of this dialogue. I'm going to start with Dr. Kane as our current president. Dr. Kane, please go ahead and ask Dr. Siegel your question, and then right after that answer, Dr. Lawson, feel free to ask your question right after that.
Well, let me just say, Dr. Siegel, I just appreciated your perspective and insight related to Medicaid and the concern that we might have a number of states who may decide to eliminate or reduce Medicaid expansion. But one of the things that I think people are very concerned about is, all during this campaign, we kept saying that we're going to reduce healthcare costs for everyone in this country. But based on these changes that are being proposed, are we going to see a reduction in healthcare costs for the average citizen here in our country? And the second piece I want to add to this is, with Medicare, we were talking about doing negotiations of pharmaceutical companies in order to get discounted medications and everything. Will that process stop as part of the reduction in cost to our Medicaid expansion or Medicare programs?
Yeah. So on your question, the people will not see their healthcare costs go down if we pull back on Medicaid. Medicaid, because it's caring for people who are of modest means, who meet very careful thresholds of having very low income, it covers their services. And people are going to see not affordability, they're going to see unaffordability. They're going to have to go, if they can get to somewhere to get care, they have to pay out of pocket because their insurance will either be less or be gone completely, to be honest. A concern I have now, I don't think this will impact Medicare and the drug price negotiation, but state Medicaid agencies have been good at negotiating lower prices for drugs as well, and having and doing formularies and the like. Again, if somebody goes from being covered on Medicaid, where their drugs are generally covered 100%, to being uncovered or on a private commercial plan, they're going to certainly be paying a lot more for those drugs. And if you've ever had to pay or seen what the full list price for some drugs are, it can be stunning. So this will not increase affordability. People on Medicaid, if you poll them, they will tell you that they feel more financially secure and they have less issues of medical debt than people who have private health insurance in this country or Medicare.
Thank you.
Dr. Lawson.
Thank you, Dr. Siegel. Thank you so much. Thank you for sharing the real world consequences, right? If these Medicaid cuts were to take place. I myself am an OBGYN. I'm based in Texas. So I clearly understand that Medicaid can be a lifeline for moms and babies. But I want to pivot the conversation a little bit. I'd love to explore with you around the long-term economic impact. What would be the return on investment for preserving Medicaid? Because I think that is a conversation, I think for those of us who are advocates in the NMA, that we need to understand that part.
Yeah, well, I think, we know that the investments that Medicaid makes in children, and children are an inexpensive part of the program, frankly, compared to, folks with more complex medical needs, well child. There is, evidence after evidence that is paid back over their lifetimes, paid back in terms of lower healthcare costs, paid back also in terms of their ability to contribute to the economy and the like. I'll also, note that this is a discussion in many ways of taking away health insurance coverage from people, a good coverage. And we know also that when people have coverage, they are able to better manage their chronic diseases, and that saves money in the long term. And this administration, and the new Secretary of HHS, RFK Jr., has said he wants to address these issues head on. Medicaid is tailor-made to do that. So we should be focusing on how to empower it to do that better, not saying, and as part of this, we're going to walk away from the table, which is right here. There's economic impacts also. I mean, there are, many cities in America where, I'll be honest, our hospitals are the most vibrant thing in the economy. And our membership, I can tell you, employs 900,000 people across the country. The economic contribution of our members to the American economy, just our state net hospitals, which are Medicaid dependent, is $280 billion per year. And that includes Marion County and Eskenazi, and that includes Howard University Hospital and many others who I'm sure represented here. We pull back here, we are disinvesting in some of the most economically needy communities, where these organizations are the pipeline for advancement. It's where people are learning professions, where they are moving ahead, where there's maybe not much other options. And we are disinvesting and sending that money to a very different place instead.
Yeah. Dr. Kane, I think we have time for another round of quick questions between you and Dr. Lawson. Do you have another question for Dr. Siegel?
I do. So, Bruce, how will this impact our Medicaid providers, our healthcare professionals? And, as it is, we don't get the same high reimbursement as patients who are on Medicare, those patients that are 65 and older. And so what will happen to our workforce with these cuts in terms of providing services out there?
Well, I think you'll see, the expansion of healthcare deserts. Already, as you mentioned, Medicaid rates are lower than Medicare, far lower than commercial insurance. And I am concerned that our policymakers will say, well, we didn't really change the program. We just cut back on how much we paid those doctors in those hospitals. Well, there comes a point where you're no longer economically viable as a physician practice or as a hospital. The numbers just don't work. You can't meet payroll. So I would be gravely concerned that we will see, oh yeah, there's no cut in benefits, but nobody can afford to practice medicine in this community, whether it's Southeast DC or Chicago or Western Kansas or other places. And that will have a dramatic impact on people's access to care. And I could see that scenario being one that's, politically palatable to some, because they can say, we didn't cut benefits. We just cut payments and save money, or cut fraud and abuse. That's what we're here, cut fraud and abuse. Okay, we'll see about it. Really that much fraud and abuse? So those access deserts will blossom, and that's not good. And again, the first places who will feel that will be the rural communities of America, who are already very much on the edge.
Dr. Lawson.
Certainly. And I would just tag on and extend her question there a little bit. Could you explore with us any impacts, and when you think about our teaching hospitals from the residencies, that residency physician support, because that's an important piece. Many safety net hospitals in our larger cities are, right, training facilities. Can we explore that?
Oh, it'll have a major and immediate impact on that. You are absolutely right. And when I look at our own hospitals, the Cook counties or the Howard University hospitals or the Eskenazis or the LA counties or, Boston Medical Center, Jackson. These are some of the premier training grounds for health professionals, physicians, but far beyond physicians. And they are part of that pipeline, which is a very positive pipeline. Many of these hospitals today are, because of the needs of their community and their mission, training many more residents than Medicare pays for. And Medicare finances most of these programs, these graduate medical education programs. So they're finding money other places to try to subsidize these programs. You walk down this pathway, they will have to pull back on that. And I think that will have many impacts. It'll impact, frankly, the diversity of our professions, who gets to be a physician in America. And God knows we have enough challenges in the last few years on that front, as you know. It will also impact, the people who train in these places. Those are people most likely to stay there. People, and I'm not telling you anything you don't know, people who it's not where you go to med school, it's where you do residency. So you start pulling back on the residencies in these communities, you are, shutting down that talent, escalator for the health professionals who are going to practice there someday. So another knock-on effect, absolutely.
Well, I want to go ahead, Dr. Kane. You can have
just real quick, and so we can get to the other questions too. But you have to think about public health preparedness. That if we don't have funding for these folks where they can access care, where they can pay for some medications, treatment for the flu, the retail's about $100.
Yeah.
But if you get the complications of influenza because you can't take that preventative medicine, you're hospitalized, you end up on a respirator, we're still paying the exorbitant cost. But if we have a public health crisis, how many of our folks won't have access? How can we curtail? We're seeing a measles outbreak in Texas, and it's even spreading to Arizona. We saw a TB outbreak in Kansas. And so just the concerns related to this, that we need to have the infrastructure in case we're dealing with huge outbreaks. And who's taking care of those people in California with all those fires? People getting injured and what have you.
Yeah, yes, very, your point, I couldn't make it any better. And we saw that during the pandemic. During the pandemic, Medicaid did exactly what it was supposed to do. It was there. You remember those early months when millions of people lost their jobs? They got Medicaid, and that paid for a lot of the care that people received in the months after that. And the Medicaid rolls have gone down a little bit since then, but they're still higher than they were before the pandemic because people discovered it as a stable source of healthcare coverage. But spot on.
I want to thank our presidents, infectious disease expert and public health expert, and Dr. Kane, and OBGYN expert, and quite frankly, a managed care expert in Dr. Lawson. And thank you both for being part of this president's panel for this discussion. Dr. Siegel, we're going to turn to our questions from the audience. Aaron O'Malley says, "Thank you, Dr. Siegel. I'm curious if you are tracking how, if at all, evolving immigration policy overlaps with Medicaid or other forms of public assistance. You have any thoughts about that?"
Yes, I think, and I thank you, Aaron, for that question. First of all, I want to clarify something. Under federal law, Medicaid cannot pay for undocumented immigrants. So you're going to hear that. Oh, it's paying for illegals or undocumented. That is not true. The federal dollars don't pay for that, and they can't. I just want to clarify that. States may decide to do that. That's on them. I think that these issues are very synergistic. As I think people become nervous about going to the hospital because ICE might be there, or nervous about giving their name because they're afraid they'll run up on a list. We saw in the last administration of this president something called the public charge rule, which said if you're on Medicaid, we can use that against you to say you can't become a permanent resident because we think you're kind of like on welfare if you're on Medicaid. You're a public charge. I expect that they'll make another run at that. So I think you have negative things reinforcing each other, where people who should be getting care, lawful immigrants in most states, are going to lose that, potentially could lose that coverage or that access to these Medicaid cuts. And that's compounded by their fear of encountering the healthcare system because they're afraid that'll in some way be used against them. And that, that it will lead to all the issues that Dr. Kane so eloquently referenced earlier in terms of what will happen on the health effects of this. So definitely a cause for great concern.
Dr. Melanie Hannah Johnson, who is the Speaker of the House of Delegates for the National Medical Association, asks, how are insurance companies viewing the downstream effects of costs of eliminating and decreasing Medicaid preventative services and the resulting increase in the end-of-life care costs?
It's a good question. And I honestly don't know. I haven't thought about that question and how they're thinking about it. It's something they should think about. I am hopeful, if only because of their own interest, that these insurers will, I believe, be allies with us in maintaining the Medicaid program, especially since the great majority of Medicaid is now delivered through private insurers, through managed care organizations. And I do think that is a good question to ask because they will eventually may suffer the downstream effects financially of untreated illness and, unmanaged disability. At some point. So there's certainly another thing. And I suspect in the weeks ahead, we're going to be seeing much more information and estimates about quantifying these things on a national level. But I think we're now at a point where these cuts have begun from being vague to being, oh, this could really happen.
Yeah. Dr. Melvin Williams talked a little bit about, asked his questions surrounding Medicaid in urban and rural communities and that impact. You answered that, but what he asked also is on long-term care. Can you talk a little bit about maybe post-acute LTACs or long-term acute care facilities,
Yeah,
skilled
so
nursing facilities, things
yeah,
of that nature.
people don't realize that Medicare for the elderly doesn't do that much for nursing homes. I mean, it might have, an episode of post-acute care, but not long-term skilled nursing for the most part. If you want to look at where, what is really supporting long-term care, what we call the long-term support services, which is, the whole, the uh, um, spectrum from long-term acute care for complex patients, or skilled nursing facilities, or residential care, or community-based care. That's Medicaid, and Medicaid is paying, the largest share of that. And so I think one thing that gets lost in this conversation is the impact we could see on those populations who, yeah, are costly to care for. Well, boy, will they be even more costly not to care for. And what a loss of dignity for people who have been able to access those services and have productive and happy lives. I don't think we want to lose that. And it's a critical part of Medicaid that often gets short shrift, and something we need to talk about in the weeks ahead more than we do currently. I hope I answered the
Um,
question there. Yeah.
Yeah, and as there's a couple other questions here, and that are going to transition us into some solution building and some thoughts about how we can position ourselves. An anonymous attendee said, "Is there anything that hospitals can do to prepare for the cuts, or what should they be doing right now?" And then the same question from the same participant, the same advice for patients in preparing for any of these cuts. So hospitals, what should they be doing right now, and patients, what should they be doing right now?
Fighting this,
Mm.
fighting these cuts, pushing back. Today we sent in the last 2 days we have activated our membership to focus fire on Congress around this. We do not take these cuts as an assumption. We do not assume they will happen. We are with every fiber dedicated to fighting them, and we've been in these battles before, and we have some allies. We have allies with the American people who like Medicaid. We have allies with a group of about 14 or 15 Republican congressmen in, seats which they could lose in the midterms. They're seats that they barely won last time. They may be in places where Joe Biden won the majority. And some of them are really expressing um, great concern about this. And, going to the speaker and saying, we really can't vote for this. We need to empower those 15. And we're happy to work with Christina or others to sort of identify those. But we are focusing our members on those people. The other people to focus on, letters, phone calls, whatever, the tools that NMA or all of you use, is the members of the House Energy and Commerce Committee. That will be the place where the rubber meets the road, probably in the month of March. And that is where we have to focus our fire. So that committee, those 15 congressmen, that's what's going to matter. And I urge you, if you work in a hospital or a clinic or any setting, whoever your congressperson is, tell them your story and tell them what this will mean to you. If 10 or 20% of this program goes away, what will that actually mean? Because we know it will be catastrophic. And we need to tell people that up front. This is what this means.
We are a group of physicians, and we like to think that we represent Black and African American physicians in this country, podiatrists as well. And what would you consider the most effective action that physicians can do to amplify this question?
I think physicians have unrivaled credibility. So whether it's through NMA or other associations you may be a part of, as part of your specialty societies or other groups, educate your congresspeople educate your senators about what this means. Educate them about the good that Medicaid does in your community. I suspect we're going to be seeing lots of folks having press events around this, writing letters to Congress, the whole panoply. And I don't want to dictate what the right method is for you, but being vocal and visible, I think is going to be very important over the next couple of months. I think we can win on this one. I think we can protect our communities, but we have to activate now.
So, Dr. Siegel, we know and we've learned from you today all of the parameters of the Medicaid and FMAP program, some of the risks that are out there surrounding the provisions within the proposed legislation for budget cuts, and then its impact in our community and how our children and how our elderly and how our most vulnerable would be impacted. And then lastly, we heard from you the fact that there is a way for us to move forward, that this is not a foregone conclusion, that we actually have some opportunity to change the trajectory towards this loss into a win. So I want to, on behalf of the National Medical Association, I want to thank you for taking the time for being with us. This is truly in the tradition of the National Medical Association. People like W. Montague Cobb, who was at the forefront of moving Medicaid and Medicare and CMS into existence, and was one of our presidents, as well as the president of the National Association for the Advancement of Colored People. And so, in the last minute that we have, I would love to ask you if you have any last words, any last thoughts for our members and for those that are attending and watching this evening.
Organize, push back, fight. I think we can win this. And I would say I'm honored to be here, honored to be a part of the discussion. And I want to thank NMA, which I remember also, for its allyship. I think working together, we can do this. And this won't be our last struggle in the coming years. That we know for sure. But I think this is going to be a very important one at the outset at this point.
That's Dr. Bruce Siegel. He is the CEO and president of America's Essential Hospitals. My name is Dr. Roger Mitchell Jr. I'm the president-elect for the National Medical Association and president of Howard University Hospital. You've been watching a presentation by the National Medical Association, the oldest and largest group of Black physicians in this country, where we advocate for equity and inclusion for our community and better health outcomes for all that are in this country. So thank you for spending an hour with us this evening, for all that have been able to tune in. And we hope that you'll stay in tune. Come to our website, www.nmanet.org. Hear more about what we're doing in community. If you're a physician, become a member. And if you're a community member, find a physician that wants to take care of you. So thanks again. Thank you to the staff and leadership of the National Medical Association for bringing this together so fast. This is groundbreaking. This is just really hitting the ground as of last week. And we wanted to make sure that we brought it to our members fast so that we could activate, as Dr. Siegel calls it. So thanks again and have a great evening.